Hi everyone. I would like to thank Dr. Ahmed Osman for the great organization of this session and how logical and very well organized regarding the topic of lung nodules, which is very, very important topic because we face it every day, actually, believe it or not. In our CTs on daily basis we see lung nodules, and we're always confused whether to call it a suspicious nodule or not. And that's why I'm going to talk today about the Lung-RADS and what are the benefits of Lung-RADS. Is it really accurate or not? Whether we should use Lung-RADS on a regular basis or should it be used on specific situations, and why. So the dilemma that Dr. Iman talked about is the solitary nodules, which is very suspicious topic because nodules are always worrisome whenever we see them. Okay, nodule by definition is a round structure. It's an opaque structure, smaller than 3 centimeters, and it is the most common finding on CT chest. Solitary pulmonary nodules, they can be malignant. I'm not going to going through them again. Malignant, primary or metastatic, or benign tumors, or even infectious diseases. Nowadays, we started lung cancer screening. It has been started in Egypt 3 months or 4 months ago, and we have a large number of data that will be published soon. And all the team here worked through the Lung-RADS during the lung cancer screening. So the main 3 pillars of lung cancer screening is low-dose CT, which is available everywhere now. We have the AI solutions. We have multiple vendors now in Egypt. We're using them, and we're using the tools, and we're aiding our diagnostic levels with AI. And we're using the Lung-RADS, the new versions of Lung-RADS. Why Lung-RADS they started to begin with? The goal was to state a recommended one way of telling and discussing the topic of lung nodules through all studies. Lung cancer screening started in 1999. And when they did lung cancer screening at the beginning, they found that more than 80% of lung cancers were detected at early stage with the stage 1 disease. That's why from this point, they started carrying on the awareness about smoking cessation and starting lung cancer screening to reduce the possibility of late stage of lung cancer and, by the way, increasing cost over the countries. And these are the different studies that went through the lung cancer screening. At that time, the ACR, they started creating what we call the Lung-RADS, which is a way of discussing what are the lung nodules, what is the importance of each and every single nodule, and whether it is alerting or not. The structure reporting that came around 20 years after the BI-RADS for the breast, and they started with version 1.0 that was created in 2014. So we're talking about like 10 years ago when they started this. And like any other topic, it has a pros and cons, and it evolves over time. So this was the beginning. This is the native version of Lung-RADS that started in 2014. And they discussed several levels, whether it is a negative, Lung-RAD 1, or benign lesion, Lung-RAD 2, probably benign, which is suspicious again, Lung-RAD 3, and then Lung-RAD 4 and A and B, which are the suspicious lesions. And in each category, they subcategorized whether it is solid nodule, partly solid nodule, or a non-solid nodule. And with time, over the 5 years, they found that they called so much nodules in a wrong way of calling them and in a more alert way of calling them. So they revised the sizes again because the sizes were not that accurate at that time. So they came with the newer version, which is 1.1 in 2019, so 5 years later. And they changed a little bit between version 1 and version 1.1. The main changes were the perifissural nodules, which are the nodules that we see in each and every single CT nowadays, because most of these are benign. There are intrapulmonary, intrafissural lymph nodes, so they are nothing. So calling them or over-calling them will call for more CTs, more expenses, more radiation for no reason. Okay, and then they discussed the size of the ground glass nodules. They said the ground glass nodules, which are 2 centimeters and above, could be worrisome. They raised the size to 3 centimeters as cutoff number to reduce calling more CTs for zero profit. And then at that time, there were several studies comparing the version 1 and version 1.1 and whether the version 1.1 is better. So first of all, introducing the periphyseal nodules. What are the periphyseal nodules? If they are typical, they are nodules sitting on the fissure, where the outline of the nodules bulges on each side of the fissure. Okay. Atypical nodules are more non-epicentered on the fissure, but again, based and having an obtuse angle with the fissure. And the non-periphyseal nodules, or unlikely to be periphyseal nodules, are the one having a main bulk in the lung with an angle with the fissure. So this is an example of a very simple periphyseal nodule, triangular, based on the fissure. So this is a benign lesion. Again, another example of a periphyseal nodules was totally benign. And this is another example, and over time and all follow-up, it is the same. So this is an intrafissural lymph node, nothing to worry about. So at that time, they said, okay, introducing a periphyseal nodule in the Lung-RADS and mentioning them as a benign lesion was very beneficial and significantly improved the diagnostic level and reduced the overcalling for CTs over the time. At that time also, they said, and regarding the ground glass nodules, they found that reducing the size came with some negative predictive values and false negative results, and they doubted the increasing of the size of the ground glass nodules, and this was a little bit debatable. Another study came later on, and they said we should compare the Lung-RADS with the description of the CT signs of the nodule itself. So what are the CT signs? Okay, not each and every single nodule, like Dr. Iman said, is a benign or a malignant nodule. Each nodule should be taken individually and should be adequately assessed. So there are several signs which can raise the possibility of malignancy, like the pleural traction sign, which is whether the nodule is large or small, whether it is falling in a Lung-RADS or certain situation of Lung-RADS. Again, if you have a traction on the pleura, this is a most likely malignant nodule. So it should be taken in consideration. The speculated sign. The lobulated sign, again, is a suspicious sign of malignancy. The bronchial cutoff sign, which is very alerting one, when you have a bronchus or bronchiole that has a cutoff ending or appearance, it's most likely a malignant one. Again, the air bronchogram sign, the tumor vasculature sign. So all these are signs on CT that we can see in each and every single nodule. The vacuole sign, the cavity sign, and this is an important point because later on they started to introduce the cavities and the cysts in the Lung-RADS as well. And in this study, they said that the combination between the Lung-RADS per se and the CT signs of each and every single nodules increased the sensitivity of the reporting, and they said they should look upon the size and the shape of the nodule itself. Another study came later on and was published in AGR in 2022, and they said they were focusing on Lung-RADS 3 and 4, and these are the categories where there are debates because they cost each country a lot of amount of money because an action should be taken, whether a further CT examination or other modalities like PET-CT, biopsy, or bronchoscopy. So these are the nodules where we should be taking care when we report Lung-RADS as 3 or 4. The objective of the study was mainly the purpose of the study to assess the frequency of cancer in those categories, whether whenever we call Lung-RADS 3 or 4, this is a real cancer or not. And by example, the endobronchial nodules were not mentioned in Lung-RADS version 101. And for example, this by definition should be called a Lung-RADS 4A. So this is an alerting one. And on follow-up, it completely disappeared. So it may be bronchial secretions, bronchocele, or whatever, and it's totally benign. So that point make them revise the Lung-RADS again. And they found that 97.8% of endobronchial categories 4A lesions turn to be benign. So again, a pitfall in Lung-RADS version 101. Lately, in this year or the year before, they came with the latest version, which is version 2022. It came in November, and they introduced 3 main categories: the atypical pulmonary cysts, juxtapulmonary nodules, and airway nodules. So in an atypical pulmonary cyst, it was introduced in Lung-RADS 3, Lung-RADS 4, and Lung-RADS 4B. The juxtapulmonary nodules, which are most likely benign, and they raised the size to almost 1 centimeter, and they said those should fall in Lung-RADS 2. Those are most likely benign. The airway nodules should start by falling in Lung-RADS2, and then if they are suspicious or more proximal or more sizable or more of an irregular configuration, they'll be falling in Lung-RADS4A and 4B. What are the atypical pulmonary cysts? According to the studies, they found that lung cancer associated with cysts form about 9.3% of the total number. And in the Nielsen criteria, or Nielsen study, they went back and they studied the lung cancer present in cysts or accompanied by cysts, turned to be 22% of the cases. So these are alerting numbers. So not all cysts in lung are benign lesions. Cysts could be very malignant lesions. For example, this is a benign cyst. It is a very simple uniform with a wall less than 2 millimeter. So this is a benign one. And it shouldn't be classified in Lung-RADS. Another example, multiple cysts like lymphangiomyomatosis, LAM. It's a totally benign condition. It shouldn't be classified. Whereas this one should be alerting because it's a cyst with an irregular wall that is measuring more than 2 millimeters. At that point, it should be incorporated in the new system. The multilocular cysts as well are alerting features, and whenever they grow in size, this is very alerting for lung cancer. And what is the definition of a cyst or a cavitary lesion? This is a bit debatable for all chest radiologists as well, whether it is a lesion that was solid and cavitated or is started by a cyst that has an irregular wall. So they said if the lesion, the cavitary part is not in the center or eccentric or irregular in shape with a main bulk of solid component, this is most likely a solid lesion with cavitation rather than a cyst with a malignancy, which is more a uniform lesion with an irregular wall. And these are the different categories of atypical cysts falling into Lung-RADS3 with the different follow-up, 6 months low-dose CT, or Lung-RADS4A or Lung-RADS4B. And they were incorporated in the new system. And this is, by the way, the system or the version that we're using in Egypt. Lung-RADS3, another example. This is a cyst that looks very benign, but on the follow-up, it increased in size. So this is an alerting feature. Another example, Lung-RADS4A cyst with an irregular wall and multiple cysts that increased in size. All of them are very alerting and should be taken action upon. Those are a few examples again, multiple cysts that are increasing in sizes, so they should be monitored adequately. And this is another multilocular cyst that turned to be a malignant lesion with a speculated outline. They also introduced the step management, which is a very accurate decision because at the basis, for example, Lung-RADS3, in the older version, they said whenever you have a Lung-RADS3 lesion, at baseline, you should do a follow-up after 6 months. If it is stable, another 6 months should be done. So this is a total duration of 12 months. So in the new system, they said if you have a Lung-RADS3 lesion, you do a follow-up at 6 months, and if it is stable, jump into 12 months from that point to reduce overusing CT and low-dose CT. This is another example for Lung-RADS4 lesions at baseline. The usual is doing 3 months follow-up and reducing it to 2 Lung-RADS2 suddenly. A new system, they said no, reduce it to Lung-RADS3 at the beginning, and then do another 6-month follow-up. If it is stable, it is Lung-RADS2, and then do the regular routine 12 months follow-up. So these are very important changes in the Lung-RADS over time. And nowadays, I believe we should use Lung-RADS in lung cancer screening. It shouldn't be used in every and single report of CT chest because it's too much calling for lung nodules, too much calling of data for no reason. Again, Lung-RADS should be just used for lung cancer screening. Thank you so much.